next talk. Next talk is, I would invite Dr. Kalpana Babu from Prabha Eye Clinic, Bangalore. The talk is Sarcoid Uveitis, is it underdiagnosed in our country? Dr. Kalpana, please.
At the outset, I would like to thank Dr. JB for this invitation. And so my talk will be on sarcoid uveitis. Can I have my slides, please? Pointer chahiye. So when we talk about sarcoidosis, it's actually a multisystemic disease, and it's a granulomatous disease which is caused by an exaggerated cellular immune response to either self or non-self antigens in a genetically predisposed individual. And the way we make the diagnosis is by typical clinical features, positive chest radiology and a positive biopsy. But an important caveat is we need to exclude infections such as Mycobacterium as well as fungus. Now this disease has caused a lot of interest because of its similarities with tuberculosis, and it is very similar clinically, radiologically as well as histopathologically. And we do not know the cause of sarcoid, that it's multifactorial. Some say it's environmental stimuli, some say it's infections, especially mycobacteria, atypical mycobacteria, and P. acne. Certain drugs also cause sarcoid-like reactions, and neoplasms such as lymphoma are associated with sarcoidosis as well. So is this disease common in India, which is a high TB endemic country? So when we look at the earlier literature, this disease was actually a disease of the developed world. However, recent reports show increasing reports from India, which is a high TB endemic country. And this is probably because of increased awareness, availability of newer diagnostic technologies such as the high resolution CT and the EBUS TBNA. And also, we are also using newer therapeutic agents like the biologics for cancers, which can cause sarcoid-like reactions. So now this disease is routinely considered in the differential diagnosis of both respiratory as well as non-respiratory diseases, which includes ocular problems as well. So the game is definitely changing in sarcoid, and more so for us because we have started to associate this disease more often with mycobacteria, as with these articles. So how does sarcoid present? In addition to non-granulomatous and granulomatous uveitis, you see this very characteristic dry eye. They all have sicca symptoms. And we've also had a case of hypopyon, which was an initial manifestation of systemic sarcoid, and very rare manifestations such as scleral nodules and conjunctival granulomas in the anterior segment. And posteriorly, they can present as vitritis, they can present as retinal vasculitis. This is typically what we call as the candle wax dripping. Choroidal granulomas, which can be unifocal or multifocal, and depigmented chorioretinal scars which resemble Dalen-Fuchs nodules-like appearance, optic nerve and head involvement in the form of disc edema or granuloma, and you can also see pre-retinal and retinal granulomas as in this case. Sometimes the inflammation will be very low grade, and it is associated with inflammatory choroidal neovascular membranes like in this case. And you can also have orbital involvement. The lacrimal glands can be involved, orbital tissues can be involved, like in these cases. So generally, when we see ocular sarcoid and a posterior segment inflammation, we usually do a fluorescein angiogram and an ICGA to look for choroidal granuloma. So this case was a partially treated sarcoid. Clinically, though they appear few granulomas, on the ICG there are a lot more. And you can also pick up retinal vascular leakages as well as retinal vasculitis on fluorescein angiogram. OCT is a very useful technology to look at these granulomas, and generally these are well demarcated and they are associated with increased transmission signals. And OCT can also be used to monitor these granulomas. They are slow to respond to therapy, and you can use this to serially look at the AP diameters to see if they are responding to treatment. OCTA is also a useful technology because it can pick up subclinical granulomas which are not visible clinically. Here there is a clinically visible granuloma, you see a hypoperfusion area, and OCT a well demarcated granuloma. Now, this area appears okay clinically, but on the OCTA you have hypo areas, and if you look at the OCT, that area has increased transmission signals. So definitely imaging has made a big difference in looking at our cases with sarcoid. 90% of these cases, when you look at them, they have lung or lymphadenopathy, and this can occur at any point of time. In addition, you can have a skin involvement or a history of Bell's palsy, like in this case. You can have glandular enlargements, like in this case, which had a parotid gland enlargement, and it can actually involve almost any organ: joints, nervous system, cardiac, renal, and even the liver. So generally, when we see a patient with sarcoid, suspected sarcoid, these are the investigations which we do: the MANTU and the quantiferon TB gold. Radiology, preferably we look at the high resolution CTs. And these cases usually have lymphopenia, especially if they are detected very early. You can have a drop in the lymphocyte counts. And sometimes renal sarcoids are associated with increased serum calcium. Liver sarcoids are associated with increased liver enzymes, and of course many of them are picked up asymptomatically on PET CTs as well. Ideally, it is always better to biopsy whichever tissue it is available for a definitive diagnosis, and this can be either from the skin or the orbit or from the lung in the form of EBUS TBNA. As we cannot follow these patients with serial HRCTs, generally we do a baseline pulmonary function and follow them up every 6 months. Now, many times the systems are absolutely normal and it is only the eye which gets involved. And this is the revised IOS criteria, where they have looked at clinical features as well as investigations and laid out certain criteria for ocular sarcoid. But the caveat is you need to rule out other causes of granulomatous uveitis, and this is a big challenge in our part of the world. So we looked at a multi-center study, and this was published recently, where we looked at diagnostic markers between ocular sarcoid and ocular TB in our patient population. And we found that these cases had a dry eye, retinal vasculitis, especially of the candle wax type, and chest radiology showing hilar lymphadenopathy and fissural nodules, then probably are dealing with ocular sarcoid rather than ocular tuberculosis. Also, this is a paper by Dr. Agarwal and group, where they have laid out certain diagnostic characteristics between sarcoid granulomas and tubercular granulomas. But there is always a challenge, in our part of the world, because there is a gray zone, and we've had patients who've had both TB as well as sarcoid in the same individual, and we've also had patients who had TB and later on developed sarcoid, and vice versa as well, prior sarcoid and who developed TB later on. And these are very challenging. So I'll just share a few cases with you. This is my first case, a young male with a history of Bell's palsy, and if you see his eye, he had keratoconjunctivitis sicca. And he had this candle wax dripping type of retinal vasculitis. However, the HRCT showed heterogeneous enhancement, which was biopsied, and biopsy showed caseation necrosis. So though ocular features were so suggestive of sarcoid, the pulmonologist was not convinced, so he gave him a course of ATT along with steroids, but he continued to develop reactivations, and eventually he required methotrexate. And it's been 11 years now I've been seeing him, and he's in remission. Similarly, this is my second case, a 42-year-old lady. Again, there's a lot of contact history. She has constitutional symptoms. Her mother and uncle who live with her had TB. So there was an exposure to tuberculosis. And HRCT did show mediastinal and hilar lymphadenopathy. Now, this was biopsied. Everything else was negative except the PCR for MTB had come positive. So this patient was started on ATT by the pulmonologist along with the oral steroids, but continued to develop granulomatous uveitis, which became pan-uveitis with time. But over a course of time, she developed parotid gland enlargement, which was biopsied, and this turned out to be a sarcoid, non-caseating granulomatous inflammation. And she was put on immunomodulation, and she's been doing well since. This is a third case. It's an intern with granulomatous, initially presented as an intermediate uveitis-like picture, and was treated with anti-TB medications for a positive MANTU, but HRCT and QFT were negative. But with time, he started developing a granulomatous pan-uveitis picture, And there was a mild disc edema which started developing. So he underwent a CSF tap which was negative for mycobacteria, and there was an MRI enhancement on the optic nerve. So the neurologist also felt it could be sarcoid, and this patient was treated with methotrexate and did extremely well. This is my last case, and this definitely was a challenge to me. This is a 62-year-old lady with diabetes and hypertension on ACE inhibitors. So actually this patient had a cataract surgery done elsewhere and was on topical interferon because they diagnosed it as Irwin-Gass syndrome for the left eye. But just a week before coming to me, she had developed her redness and pain in her right eye, and her ophthalmologist had started her on topical steroids. So if you look carefully, right eye has a medium-sized keratic precipitate with synechiae and cystoid macular edema as well in both eyes. So an FFA showed leakage with CME, and the cystoid macular edema was confirmed on the OCT. So we looked at also our probable working diagnosis was either a TB or a sarcoid, and we went ahead and did all the investigations. And what was surprising was the lymphocytes count was down. She had lymphopenia. Serum ACE was on the higher side of normal, but she was on ACE inhibitors. MAN2 and quantiferon was negative, and TBNA showed non-necrotizing granulomatous inflammation, which was AFB negative as well as gene expert and PCR negative for mycobacteria. So everything fitted into sarcoid, and she was started on oral steroids. And what was interesting is 3 weeks down the line, I was told that her culture had come positive for Mycobacterium fortuitum. So the whole thing changed. The whole presentation looked like a sarcoid-like reaction, and the culture came out as atypical mycobacteria, and she had to be treated with amikacin and linezolomide as well as moxifloxacin. So I'm coming back to this article, which is very interesting article, where it says that mycobacteria might be members, so there could be slow growing types with low pathogenic potential, and they can elicit a type 4 kind of immune response, which we generally see with sarcoid. And interestingly, in this meta-analysis, 30% of the cases had an overall positivity of mycobacterial DNA in sarcoid samples. So thus, what I would say is sarcoid is definitely increasing in our part of the world, but its association with mycobacteria, both typical and atypical, poses diagnostic challenge in ours, and there is always a gray area which is very difficult and poses a diagnostic challenge for all of us when we treat. So what I can say is these cases definitely, if you are suspecting an infection, it's better to treat it with the antimicrobial therapy and watch them for long periods of time. I thank you all for patient hearing.
Thank you, Dr. Kalpana, to bringing out the challenges of sarcoid uveitis. Indeed, like tuberculosis, sarcoidosis can also have protein manifestations and pose a diagnostic challenge, particularly in our country. It's such a close mix-up between the sarcoid and tuberculosis. It's often difficult to differentiate between the two. There are certain markers, like one of the work has been done by Dr. Underdiagnosed, who has showed that the choroidal granuloma is much more in number than in sarcoidosis than tuberculosis, choroidal nodules. Also, the OCT pictures are some characteristic findings. But still, we have got a lot to learn to distinguish between the sarcoid and tubercular uveitis.